Welcome to GHAPPcast, the official podcast of gastroenterology and hepatology advanced practice providers. I'm your host, Christina Hansen. Thank you for joining us for another insightful episode where we dive deep into the world of GI and hepatology. Today's episode, entitled Mastering IBS-C, Diagnostic Strategies, Differentiation, and Management, focuses on enhancing our ability to educate and discuss IBS-C with our members and our patients. Joining me today is another GAP member, Kim Orlick, a seasoned advanced practice provider and expert in the field. Welcome, Kim.
Thank you for having me today, Christina. It's an honor to be part of this podcast.
Together, we'll share the hurdles we've encountered in our practices related to diagnosing and managing IBS-C, discuss strategies to overcome these challenges, and answer some of the most common questions we receive from patients. Questions that we've also gathered from you, our listeners. So whether you're on your commute, taking a break, or tuning in from your clinic, get ready to gain new insights and tools to help you have more meaningful and effective conversations with your patients about IBS-C. Let's get started, Kim. Welcome to the show. So, Kim, let's begin by talking about this shift, if you will, in the way that we go about identifying and diagnosing our patients with IBS. You know, historically, and you're a lot younger than me, but I've been around and this isn't my first rodeo. You know, back in the day, we used to call this a diagnosis of exclusion, right? You rule everything out, throw it in a bucket, must be IBS. But now we have this shift in the way we go about approaching patients with symptoms that are very consistent with IBS. It's called this positive diagnostic strategy. What is positive diagnostic strategy, and how do you go about diagnosing IBS in your practice?
Yeah, great question, Christina. And so I agree. When I started, IBS was a diagnosis of exclusion, right? This is what we were taught. And you had to do this significant workup and tests and money and really prolonging giving patients a diagnosis. And the yield of those tests, as you've seen similar to me, really was very low. And we ended up at the same place after a lot more expense and time. So in my eyes, I really appreciate the shift to positive diagnostic strategy because I truly think we're able to give patients an answer and a diagnosis and get them on therapy and help them sooner. So to me, this is really a way to diagnose patients based on the presence of their symptoms. And I really think about it in kind of three things to get us to this positive diagnostic strategy. The first one is really ensuring that that patient sitting in front of me fits that room criteria. So whether it's constipation, diarrhea, or mixed, we know they have that pain component. We know that that pain is related to defecation, getting better, getting worse, and then that bowel-associated symptoms. So first part, again, is that room criteria. That second part is ruling out any alarming features. And I think for APPs, this is so important because almost all of these alarming features can be elicited with a really good history, right? So this is asking patients about rectal bleeding, asking them about weight loss, asking them about nocturnal stools, really getting into that family history and making sure that there is no increased risk of colorectal cancer and IBD and celiac disease. So the one part of those alarming features that does lead into our limited diagnostic workup is at least getting a CBC and making sure we're not missing anemia. So again, that ruling out alarming features is kind of part two for me, mostly history and a CBC. And then really that last part is, are there any other tests that are really necessary? And I know you touched on guidelines and ACG and AGI, and I really try and follow these for that third part. Yes. So when it comes to constipation, again, having that CBC, I often incorporate thyroid testing if it hasn't been done on my patients. And then as we look a little bit towards the diarrhea patients, and I think this guideline is really great to help us with what we should and shouldn't do, is also checking that celiac serology, the inflammatory markers, including CRP and fecal calprotectin, and again, that CBC also in those diarrhea patients. So, you know, I think the big takeaway for APPs listening is we now have a really good way to confidently and accurately and limiting unneeded tests and decreasing time for patients to really, with confidence, get them this accurate diagnosis.
Absolutely. And as you know, there's data around this. You know, there's data around this positive diagnostic strategy that by assessing a patient per Rome 4 criteria, ruling out alarm symptoms, minimal to no, testing may be
Yep.
necessary depending on, like you said, what they've come in with recent blood work. And really you can have a 98%
Yep.
confidence in IBS as a primary diagnosis
Yep.
without having to do a lot of testing, and
Yep.
certainly not repeating colonoscopy. How many times do patients bop around from provider to provider and they get another colonoscopy?
Yep.
These are long-standing symptoms. A patient might come in and say, well, they've worsened. Well,
Yep.
worsened over the last few years. Okay, well,
Right.
that's different. Just a sudden onset. These
Yep.
are younger individuals. The alarm symptoms, if there's no alarm symptoms, if they meet criteria for colorectal screening based on age, that's a different, matter. But
Right.
they come in and they've had multiple colonoscopies. And we also have data behind that. I think it was Dr. Bill
Yep.
Che that did a prospective study looking at the incident of increase of structural abnormalities in patients with IBS versus healthy controls, and did not find that there were any increase
Yep.
abnormal findings on colonoscopy, polyps and
Yep.
cancers and things like that. So unfortunately, it's a huge cost, a strain, and unnecessary testing that is repeated over and over again because these patients tend to bop around. And part of that is the feeling that these patients have of not being confident in their diagnosis, because historically they have not had a provider who has been confident in giving them that diagnosis. So
Yep.
they feel there must still be something wrong. And so they'll go to different providers. It's not an easy thing to talk about. They don't feel validated. So they fall off the edge for a couple years. They come back to a new provider. And unfortunately, they get repeat testing and probably repeat trials of therapies, such as over-the-counter therapies that really weren't very effective in the past, but because they're new to
Yep.
this provider. And again, there's that lack of confidence. And so we see the data around this delay in diagnosis, years worth of delay in diagnosis. So the positive diagnostic strategy is really in place to get these patients diagnosed confidently and early and get them on treatment quicker. So
Yep.
very, very strong data supporting that. And it's definitely something that we're utilizing more and more. So speaking of Rome 4 criteria, and as you know, literally a group of experts came together in the 1990s in Rome to come up with different criteria around functional GI conditions, and that included IBS. And now we're on our fourth iteration, Rome 4 criteria, which really by definition, as you were alluding to, is recurrent abdominal pain occurring at least one day out of the week or more in the last 3 months, and has to be associated with at least two of the following criteria. So it's abdominal pain associated, related to defecation, abdominal pain associated with a change in frequency of stool, and abdominal pain associated with a change in form or appearance of the stool. So that abdominal pain is really that cardinal symptom that differentiates IBS from other types of constipation or other types of processes. When we look at IBS and constipation, how do you differentiate in your practice IBS with constipation from chronic idiopathic constipation, for instance?
Yep.
What's the differences that you see there that
Yep.
let you know that, oh, I think I'm thinking chronic idiopathic over here?
Yeah. So you really hit on a lot of it, Christina. So obviously, these two conditions overlap a lot, right? We know that the bowel issues with the constipation, whether it's the decreased frequency, whether it's the straining, whether it's the hard stools, but that abdominal pain, that visceral hypersensitivity is really
Ooh,
that big difference to me because we know that the other abdominal symptoms, the bloating, patients
yeah.
have bloating with CIC, they have bloating with IBS-C. So that pain is really that cardinal symptom that really helps me to differentiate where those patients fall on that spectrum. And
Mm-hmm.
I think the pain is where a lot of the IBS-C patients are really frustrated, right? And I really try and explain to the patients, you mentioned a lot of these patients, they've seen one, two, three healthcare
Yeah.
providers before coming to us. And I think their frustration is going back to what we started at the beginning is nobody's actually given them a diagnosis. They've had tests done and they've been told, this is fine, this is fine, this is fine. But the patient's like, I hurt. And I really try and explain to those patients what that visceral hypersensitivity is.
Yeah.
And so we know, and I tell them, we know that we all have stool, we all have gas in our intestines. For patients
Mm-hmm.
with that IBS-C, it's not hurting as it stretches the lumen. But we know that for patients with IBS-C, it hurts and they have increased pain receptors being sent to the brain. And when they hear that, you can see the light bulb going off that
Yeah.
we are actually listening to their pain. We are acknowledging that they have pain and
Yeah.
we understand why we have pain. I know we're going to move into therapies, but then I think it really helps them when we say, we have therapies that not only are going to help with your bowels, but they're going to help with that pain. They're going to decrease that visceral hypersensitivity and that pain response. So it's so important when these patients come in with constipation or with bloating that we really do ask about their pain so that we can give them that proper diagnosis and where they fall, whether it is IBS-C or CIC.
Yeah, absolutely. And I think, in another podcast, we take a deeper dive into the pathophysiology of IBS. But to your point, it's very complex, and it's really important to have education around the pathophysiology with our patients. I think it's really helpful because these patients do often feel there has to be something wrong. This can't just all be in my head. And when
Yeah.
you start to have that conversation around the complex pathophysiology, the different pathways that are contributing to the symptoms patients feel, you can say, actually, yeah, there is something going on. There is
Yep.
something under. Let me
Yep.
explain this to you. And you start talking about the altered motility. You talk about what does increased intestinal permeability mean? What does that lead to? What is this visceral hypersensitivity? Guess what? That's the pain that you experience. And guess what? That pain is what leads my patients in and out of the ER with IBS. So being validated, and when they can actually claim that diagnosis, when they can understand that there is actually something going on and there is something that's manageable, but it's going to give them symptoms, that it's not just something they're creating or not coping well enough, they can claim that and be empowered and feel validated, especially when their provider can be confident in that and explain that. And then they can go to their friends and say, oh, guess what this is? Visceral hypersensitivity, and it's a big word and it sounds scary. And oh, my visceral hypersensitivity is acting up. They can actually put a name to it and feel confident in that. So I think it is really important to have a discussion around the pathophysiology because it really helps that person understand, feel validated, and know that there are things that we can do to work on it. So yes, a person with chronic idiopathic constipation or colonic inertia, yeah, if they haven't had a bowel movement in 10 days, they're going to kind of feel bloated. So there is some discomfort there, but it's
Yep.
not the same as that visceral hypersensitivity, that significant abdominal pain that our patients with IBS. That really is that cardinal differentiating factor. But a lot of the other does overlap: straining, harder stools, sensation of incomplete evacuation with both IBS and CIC. So it really has to be that cardinal abdominal pain. So it does take some deeper dive for us as providers to pull that out and tease that a little bit. When you have a patient, Kim, that comes into the office and they're coming in with chronic constipation, and a lot of the description, there's a lot of overlap there. On a lot of our patients with IBS, predominantly, it's usually 2/3 of patients with IBS are female. When do you start to consider pelvic dyssynergia or pelvic floor dysfunction when you have a patient coming in with constipation? What are the signs and symptoms, or what are some of the questions that you're asking around that may
Yeah.
lead you down that path?
Yeah, great question. So for those of you listening, I want to start by saying, what is pelvic floor dysfunction? Why do we care about this? And that really leads into who I start to question and why I start to question them. So this is kind of that impaired relaxation, the inability for our pelvic muscles to really coordinate, to allow our pelvic muscles to do what they need to do to have a good, complete bowel movement. So the patients I think this in, Christina, is a few different things I really think about. So first one is those patients who come in and they mention to me, I need to do any sort of manual maneuvers, manual disimpaction, anything where you feel like there's some sort of anatomical issue there that isn't working. And I know we'll talk about testing and things for that. Second one is patients who try therapy and either the therapy or therapies don't work, or they have only very short-term success and then stops working. And then you put them on something else and it's the same thing. Very short-term success and it stops working. The
Mhm.
really important message, and you mentioned females, and I think it's so important that APPs start thinking about this when we see patients with constipation, is I really ask all my female patients who come in with a constipation about their pregnancy and surgical history. So,
Yep.
and you've probably experienced this. Your patients are
Mhm.
like, I'm 70. Why are you asking me if I have children?
Right.
And I'm like, look, there's a reason to the madness of questioning is what I ask them is, do you have children? And if they say yes, did you have your children, any of them born vaginally? And
Yeah.
if the question is, or the answer is a yes, I ask them about any really large babies, any tears on your own, any episiotomies,
Yep.
any forceps, any traumatic deliveries. I ask them always about, do you leak urine when you cough or sneeze? And I think this is something that patients don't want to outwardly talk about, just like
Mhm.
fecal incontinence. So
Mhm.
all of those are kind of the ding dings to me, whether
Yeah.
patients elicit it or whether I ask about it, for me to really start thinking about pelvic floor dysfunction. And you probably see it as it's pretty common, right? So it's not something I jump to immediately for testing, but it's something that I start asking right away with my constipated patients. Men also, because we will see this, but I agree more common in females. The other thing I
Mhm.
ask about is any abdominal pelvic surgeries, rectal surgeries, anything that could have really impaired the structure of the pelvic floor and or the sphincter muscles.
Yeah, absolutely. And I think that with that constipation as well. But we recognize the big thing I think is to your point too is that those different manipulations or maneuvers, the digital splinting to
Yep.
defecate. This idea of I just can't get it out of the rectum. So I always when a patient first presents to me, brand new, and they're talking about constipation, I always say, "What does constipation mean to you?" And I try to help them understand that. Is it that you go days in between without a bowel movement and no urge to defecate? Is that you have a harder stool that you have to strain with, or harder or larger or smaller but harder stools that you have to strain to evacuate? Or is it just that you just feel like you can't get the stool out, but sometimes it's actually a soft stool, sometimes it's
Yep.
loose stool, but they just can't evacuate it from their rectum.
Yep.
If that's the case, that and they need to splint, or they're bobbing back and forth on the commode to rocking back and forth, and just to your point, all that history behind deliveries, episiotomies. Do I have some concern that there might be some pudendal nerve damage in those older individuals from an earlier in life a delivery or episiotomy and such? So that's when I'm starting to think, maybe a little bit more. And can you have IBS and have pelvic floor dysfunction? Absolutely. And
Yep.
so I think those initial visits, one of the first things to do, and it's not everybody's favorite thing to do, but I still think you can get a lot of information on a rectal exam. So I think it's important when we talk about the minimal evaluation, we might need to think about if this is a little bit of a flag. It certainly is reasonable to always perform a rectal exam in the office and get a little bit of an initial baseline. Uh, depending on what you're seeing, and like you said, how they're maybe responding to those initial therapies, when do you move to further testing beyond, that rectal exam after the trials of therapy and they're not having good response? What tests do you move on to at that point, Kim?
Yeah. So I think a lot of this, I'm very fortunate, I'll admit, where I work. So I think a lot of this is dependent on where APPs are and what tests they
Mhm.
have access to. And that history that we just talked about really drives the test I do. So very often, my first go to is that anal rectal manometry. So, as
Cool.
mentioned, if there is a patient who's mentioning, I can't empty, so they don't feel that motility part, they just either don't feel that sensation to go or they feel like they really
Mhm.
struggle with that evacuation part. So very fortunate to have anal rectal manometry, very
Mhm.
often pick up pelvic floor dysfunction with that. We also have MR defecography where I practice. So this is really helpful for those anatomical concerns, right? If we think that there might be a rectal seal or things of that sort. I also am fortunate enough to have SITS markers. So I don't do those all the time, but there are
Mhm.
certain cases where multiple therapies have failed and or patients
Mhm.
really want to know the why. Like, why do
Yeah.
I have constipation, right? And then I think it's really helpful with that 6 marker study because we A, know are there an abnormal amount of those bands left in them, but B, where are they? And so
Yeah.
with pelvic floor dysfunction, we're really going to see that things move okay through their colon, but then when it gets
Mhm.
to the rectosigmoid area, they're just all hanging out because it really is that emptying pelvic floor issue.
Yeah.
So again, I think the important part for everybody listening is that we really think about those patients that are struggling with the therapies we have or who have those risk factors we talk about. And if they're
Mhm.
not having success with therapies, to really dig a little bit deeper based
Mhm.
on where you practice and start to think about some of those other tests for pelvic floor issues.
Yeah. Yeah, fantastic. And again, it can add a lot of meaningful information for patients, for us as providers, and help us to know, would they benefit a little bit more, not only pharmacologically, but also maybe with some pelvic floor therapy. And we have a good group of pelvic floor therapists in the area. And I think there's a ton of benefit, and it's probably underutilized, really, both testing
Agreed.
with anal rectal manometry and pelvic floor therapy, which can be very, very beneficial for our patients. But we have to think about that and do that type of testing, and maybe take a pause on burning through more and more therapies, and take a pause and say, okay, I've got to think of a little bit outside the box. There's something else going on here. So yeah, absolutely. When we talk about treatment, we know that our patients with IBS, many of them, are not necessarily misdiagnosed, but not confidently diagnosed. And for many years, they're bopping in and out with different providers in their primary care and specialists. And they've tried many, many different over-the-counter therapies, and some of which can be very effective for a percentage of our patients. But IBS, we know, has a kind of a pattern of waxing and waning, and there's periods where it's better and periods where it kind of flares, if you will. And so there are a lot of different therapies over the last 20 years that have been approved, FDA approved for IBS with constipation. So when we look at the current treatment landscape of pharmacologic treatments and prescription therapies, we do have a lot in our toolbox that we can go to, including different mechanisms of action. So when is it in your practice that you're chatting with a patient? How do you go about talking about the different therapies that we have that are FDA approved by prescription in looking at what they've tried over the counter? When do you make that move into the world of a prescription therapy? And tell me a little bit about the different therapies that are out there in the current landscape.
Yeah. So great question. I mean, I think we're really fortunate now when it comes to treating these IBS patients because we do have more options, right? So usually I think for multiple reasons, a really important part is, again, going back to the history. So with all these patients, my first question is to these patients, what have they tried? And I think this matters for us to not frustrate the patient more by recommending, again, something they've already tried and we know hasn't been successful for them. Obviously, the second part to that, as we all know, is often to get the patients on prescription therapy, we need documentation for what these patients have tried and failed. So I do think it is really important for both of those aspects that we take the great history of what has been tried and has or hasn't been successful and why. The other thing I want to call out is I think over-the-counters, many of them are really successful with bowels, but I firmly believe, and I know we touched a little bit about guidelines, when it comes to truly the bloating and that pain, visceral hypersensitivity component, I really do believe that the majority of patients need to be escalated to a pharmacologic option. And I know we'll talk a little bit more about this, but then it becomes which one, right? And I think that there really isn't a one size fits all. And I really do think about the different dosing of different therapies, the side effect profiles of different therapies. Obviously, some of these patients have come in and they may have already tried a prescription, be it with another provider or with their primary care physician. So obviously there, if it was successful, it's something I might try. Some of them have different doses. I might try it at a different dose depending on how they were dosed. I think the other really important concept as we take a history of what patients have tried is how long did they give that therapy? And so it's really important to remember when we talk about this pain component that a lot of times with almost all of these therapies, their bowels are going to improve first. But if these patients didn't give the therapy long enough, there's a good chance that they may have improvement with their bloating and or pain or general abdominal symptoms if they give that therapy a little bit longer. So yes, there's not a one size fits all. We do have multiple secretagogues now on the market. We also have a newer therapy that works through the sodium hydrogen channels. So for me, I really try and factor in, obviously, insurance plays a role, but what the patient has tried, tolerability in terms of side effect and dosing.
Yep, absolutely. No, you're exactly right. Is what have they tried? And I think it's important just to have a conversation with that patient that there are other options. There are options, and we want to give them enough time. If there's any minimal side effects, we give them medication for constipation. More often than not, the most common side effect is diarrhea. And with our patients with constipation, sometimes they're like, "Please, please, I want diarrhea," and give me diarrhea. But that's usually mild and transient with really any of these different agents that we have. And to your point about the improvement of the bowel pattern. A lot of times the abdominal symptoms are what's most bothersome for our patients, especially that bloating, right? So difficult to improve for our patients, so quality of life affecting. So we want to make sure they're not burning through these therapies, and then do we just not adequately give them enough time? So it's having that conversation around, just to your point, what have they tried? What is something that they can be compliant with? There's once daily, we have twice daily therapies, and making sure that they understand there's a certain tincture of time we want to give behind the therapy before we necessarily move on. But again, sometimes they're going to be stable on something for a few years, and maybe there's a change and a shift, and there are other things that we can try. So it's moving, kind of shifting between them, having a conversation around what's out there, and the secretagogues we've had around, so secreting, so bringing in the fluid to increase frequency and soften stools, and then the sodium hydrogen exchanger that we now have works a little bit differently, blocks the absorption of sodium, so sodium stays within the lumen of the intestine and colon, and thereby increasing frequency and softening stool. So there's different mechanisms of action. Again, just having that conversation and having it really be a shared decision-making process with our patients, saying, leveling, have a level set early on in your relationship with your patient about, hey, IBS is going to be something we're going to be walking through, kind of long term. It's not something we can completely cure, if you will. And it's definitely going to affect your quality of life. May not affect your lifespan, but definitely going to affect your quality of life. But we have a lot of tools in the toolbox. So, let's give something a try, and really having that conversation around goals. What is response versus adequate response? And that's going to be very subjective. But we want to make sure as a provider that we're on the same page as our patient with what for them is adequate response. Can't completely get rid of this, but what's going to be the most quality of life we can get you to for now, and knowing that in the future that we may have to pivot, and that's okay. But having those goals try to align, and trying to make sure we respect what their processes are, what they're looking for, and knowing that there are a lot of different things in the toolbox. That's kind of pharmacologic therapy that we have FDA-approved therapies for IBS with constipation. But there are other things that we can do non-pharmacologically. And one of the things that comes up a lot is talking about diet. Patients want to know, if I cut something out or if I change it, can I get rid of this completely? We get a lot of that. And patients are pretty bought into diet and gut microbiome and those kind of things. What do you talk to your patients about when it comes to IBS with constipation? What are some of the recommendations that you talk about regarding diet, Kim?
Yep. Great question. Look, and I think this is complicated because I don't think every patient's the same. So I do think there's strong recommendations supporting soluble fiber. I'm all for soluble fiber in food form over pills or powders personally. And I explain to my patients the global health benefits of fiber in general. So I certainly do start with making sure that they're getting enough fiber. I think there's always, of course, this careful balance we have to play with these patients of fiber, because we know if they do too much too fast, we might increase their symptoms, particularly their bloating. But fiber is certainly one. FODMAP, I'm sure everybody has heard of before. So I have some strong feelings about positive and negative of FODMAP. I think my biggest takeaway is we have really good data that FODMAP helps some of our IBS patients. It helps their bloating, it helps their pain, it helps their global symptoms. I think my concern is always how strict it can be. And I feel very strong that if we're going to recommend FODMAP diet, we really should have these patients do that under the assistance of a dietitian and make sure that they really have a certain amount of time where they're doing the restricted FODMAP. And if they're seeing benefits, really trying to reintroduce, because otherwise I do think it can really lead to some long-term restricted behavior, and even some dietary nutritional deficiencies. So I think that's one of the big parts. But again, there's great data for FODMAP. I also often will have a conversation with my patients that maybe FODMAP is a little bit too strict, but there's certain part of FODMAPs, for example, just less bloating and gassy producing foods that we know just limiting some of those, but not quite as strict as FODMAP might help. Most of these patients, not all of them, have sometimes tried to avoid either gluten and or dairy. And I think in my experience, those are two of the things that are worth trying if patients really want to go more the holistic, natural approach. And we know in general that those, again, are two of the foods that seem to increase a lot of these overlapping bloating and gas symptoms. So I do think, it's really important that we have a good understanding of there are dietary options, but I think this goes back to kind of the expectation. Like, I think every patient is really different, and some of them really want to go down the dietary part, and we should be able to support them. And some of them have already tried it, and I think we really want to know what they've tried so that we don't go through that again. I think this goes back to what you said, Christina. Like, I think with these patients, the expectations are so important. I think making sure that we as providers are on the same page with our patients and helping them set those realistic expectations. And to go back to the pharmacology, I think we didn't used to have so many options, and we're fortunate now. And I think when patients come in after being on a diet and or a pharmacologic option, it's really important that we don't just allow them to say, I'm okay, right? I think it's a different time for treating IBS where we really should be digging a little bit deeper and asking the
Mhm.
patients what has gotten better and what hasn't, because now we do have other options that we can shift or pivot patients to if certain symptoms are better, but other ones aren't. Before we had all these options, it was you're better, we'll kind of accept that. But now we do have a lot more in our toolbox that I think gives us a lot more options and a lot more opportunity for APPs to really listen to those patients and drill down what's better and what's not.
Yeah, I think the active listening is so important, and making sure, again, that your patient, you can have that trust in that relationship and that they can really express their opinion. Because A, it's not an easy thing to talk about, right? And B, many of these patients, again, like I've alluded to earlier, have been through multiple different providers. They've not felt validated, they've not felt confident, and they've not felt empowered. So giving them that opportunity to feel free to talk about their symptoms and to be honest. And as you said, to just really drill down a little bit more than just, are you feeling better?
Yeah.
Because any amount better doesn't necessarily meet their goal. And so trying to maybe quantify that a little bit, put some percentages on pre and post management, whatever pharmacologic, non-pharmacologic, or dietary, and see if there's always, if there's ability to even get even better,
Yep.
some amount of gain for that patient, because there are a lot of different options. And talking about the diet too, just to your point, a lot of these patients have already come in. They've self-selected off different things. They feel like food is they have an allergy or that it's triggering it. And more often than not, in fact, our society guidelines recommend against food allergy testing, even though they feel like they eat something and it gives them symptoms, but it's really what's happening at that level of the gut, right? And so
Yep.
it's kind of trying to have that education around clearing up some of those misconceptions our patients have. Basic guidelines, recommend against the allergy testing, but that's still something our patients bring up very frequently, unless
Yep.
a very specific food reproduces over and over again. And we know that a lot of times that a true allergic reaction tends to be more of that atopic reaction, or a dermatologic reaction, and not so much the GI. It's really that IBS and that level of that gut microbiome. And so having that discussion around it, a lot of these patients have been very restricted. And so when we do talk about low FODMAP or some of the other restrictions that we may have that patient do, I really want that patient. It's really for that patient that I feel is motivated, that maybe doesn't have a concern for eating disorder in the past. These tend to be, again, female patients, younger patients that do have a lot of coexisting psychologic anxiety, things like that. So there's a little bit more of a risk there with restricting them even more. The positive data is out there in the literature around FODMAP or low FODMAP, but I think you're right. You have to tailor it, well to that patient who would be
Yep.
motivated, who you're not worried about, restricting, and for only a certain limited amount of time. This isn't something that we want to do long term, but there is data around that for sure, and that's something that to have a discussion with our patients about. And I think it's really helpful to, if you have the ability, to bring in that dietitian as well. So one of the things that we use for diet modifications for really is that symptom of pain and bloating, right? Definitely the diarrhea portion of it, but it's in the constipation portion. There may be some gain with that gas bloat that our patients experience. We can throw medications at them, a lot of times improve the bowel pattern, as we talked about, but really that those abdominal complaints are some of the biggest issues for our patients, and quality of life affecting symptom is that pain and bloating. So when we talk about optimizing management and therapy and best practices for the patient management, what do you find is very helpful when it comes to that pain and bloating that our patients experience with their IBS?
Yeah, I mean, I think there's so much, right? I think we hit on a little bit for pain and bloating, just the importance of recognizing it, right? So I think our
Right.
first job as APPs is just to listen and recognize and explain to the patients that we really hear them and we understand that they're still feeling this.
Mhm.
So as you mentioned, with pharmacokinetics and the pharmacologic therapies, a lot of times certain symptoms are going to improve. I think, again, just to
Mhm.
highlight that certain symptoms are going to take longer to improve,
Mhm.
right? So I think one of our jobs is to really encourage and empower the patients to understand the timeline of the expectations of therapy.
Mhm.
So I do make sure that they usually get at least to 2 to 3 months on that therapy before they
Cool.
say, hey, this therapy is really not working for those
Mhm.
global symptoms. So we talked about diet, whether it's FODMAP, whether it's trying dairy or gluten free. If those things still haven't worked, I do sometimes turn to other adjunct therapies. I do want to call out for those of you listening, if you haven't read the ACG guidelines on IBS, I do think that every APP in the GI space should read those. And so, as you mentioned, I don't recommend the allergy testing, and I explain exactly what you said to my patients. But there are certain things like peppermint oil that I have found really great experience for patients with residual symptoms for. So that is one of the things that I will often try. Depending if I have a concern for maybe overlapping SIBO in some of these patients, I might do testing for things that can overlap in these patients like SIBO, or consider empiric therapy for things like that. So I think the biggest part is taking that great history, seeing what symptoms have improved, making sure we've given that therapy a long enough time, considering the adjunct of different dietary options that we can talk through with those patients. And then depending on what those persistent symptoms are, really trying to figure out in an individualized way what other things we can do to help further improve their quality of life and symptoms.
Yeah, absolutely. These patients, it really is a journey, and I've said this before. Medicine in and of itself is an art at times, and no greater art than the patient with IBS, right? So it's very subjective. It's very complex. There are a lot of different pathways working in concert to give the symptoms that our patients have with IBS, and so it really is important, as you said, to set the stage, validate the patient, explain what's happening in this pathophysiology, get a good idea of their expectations, what they've tried, clear up any misconceptions they have around IBS, and really give them a trusting relationship where they can feel validated and open to sharing their goals and their opinion, and really having that good, solid base with our patients. And then, pivoting when we need to, making sure that they're staying connected with us, that we're giving them time on their therapies without burning through things too quickly, but also making sure that we continue to educate and understand what their goals are and align with that. So fantastic discussion today, Kim. As we wrap up this episode, I just want to thank you so much for joining us and sharing such valuable insights. It was fantastic having you here.
Thanks, Christina. It was a pleasure discussing these important topics with you and our listeners. I hope we've provided some really useful strategies and answers that can empower our fellow GI and hepatology APPs in their patient conversations.
Absolutely. And thank you, our listeners, for tuning in and for submitting your questions. We hope this episode helps you feel more equipped and confident in discussing IBS-C with your patients. Remember, you're not just providing care, you're educating, which is a vital part of our role as an APP. Make sure to subscribe to GHAPPcast on your favorite podcast platform to stay updated with our latest episodes. And don't forget to explore the growing GAP ecosystem further. Visit our informative website at gap.org and connect with us on Twitter at GastroHepApp and Instagram at GastroHepApp for the latest updates, insightful content, and exciting announcements. Until next time, this is Christina signing off.